And, okay, where are you, okay.
Okay, so just start by giving me your name and sort of your title of sorts.
Patricia Curtin, MD, and I'm Section Chief of Geriatric Medicine and Medical Director of two of our medical units, the acute care of the elderly units.
And also a caregiver.
And also I'm a caregiver of the daughter of my dad, who had suffered with chronic kidney disease for several years and who recently passed away. So I come at this from both perspectives.
So what brought you here today? How did you end up here?
I went to the conference last year, and I really, when my dad was alive, interestingly enough, I went because I really am interested in this, taking care of a lot of older patients, running 2 units, and I'm a nursing home, actually. This is, one of our chronic diseases that we really need to be good at, and I thought that it just sounded really interesting. After attending last year and seeing the patient and clinician combination of speakers, I love that, and today, once again, did the same thing, and I'm sort of rethinking how we do some conferences, bring in some more patients' perspectives into our conferences. So I wanted to learn more. I have a different perspective this year because my dad passed away, not really from his kidney disease per se, but from some other circumstances. But having been on both sides of this now and in 2 different points, 2 different Septembers, so I thought it would be really good to attend again, and it certainly, I think, surpassed my expectations, actually.
What have you gained in the intervening year between last year and this year? How has that changed for you?
I think, today I did make a comment. My comment was sometimes when you say that a patient has chosen not to do dialysis, it becomes the refusing dialysis, not doing dialysis. And actually, what I heard today were there are other treatment options, and especially with the last speaker, how we could say it as conservative treatment is an option. And it's a much better way to say it than saying no dialysis, and it depends on who the recipient is listening to those words. That means no dialysis. Does that mean no care, no more treatment, no more, no more anything? And so I think from that perspective, if we just maybe choose different words. Now, I have to say we've been blessed by a great team of nephrologists and with the Nephrology Associates. So anybody who took care of my dad as an outpatient. Probably don't want me to mention any names. I don't know if you do or not. But so Dr. Lindsay Slater, who I didn't get to mention today, was his primary care provider as an outpatient kidney doctor, a nephrologist. And then on the inpatient side, he had a couple of nephrologists, Dr. Gavin and Dr. Mulhalter. I think those were the 2 main ones. Oh, and Dr. Jeffrey Saccone. But and everybody, they were all on the same page about taking care of my dad in the hospital with his kidney disease. We were going to manage it with conservative treatments, and yet what we would hear on rounds or whatever was that, it was no dialysis. I'm like, but I really love the terms of conservative treatment. We treat with medications, some diet limitations, watching his fluids, things like that. He actually didn't suffer from any of the diet, the fluid overload or anything. So we were very fortunate that he was able to actually live independently at home without dialysis and did fairly well. I think, so from that, I guess just learning sort of how to manage a patient. Of course, in the last year, my dad in particular, with the help of a team of people, the nurse practitioners in the practice, reviewing the dialysis options and going over it with Joanne, for example, and what our options were. So I feel like I've gone through the experience both personally, and it's also helped me professionally, I think, to be a better healthcare provider for the people that we care for.
Where are the opportunities that you see for better care delivery?
I think understanding the goals for the patient, and I think everyone's very busy, so it's hard to have those conversations. But somewhere along the line, I think we have to just make sure that we know what the goals are. This last speaker did say, they actually put right on their outpatient list, CKD, conservative management, CKD, hemodialysis, so they have actually options. I think that that's great, and then sort of sharing that information, making sure everyone's on the same page, and again, saying that conservative management means what? That means, doing X, Y, and Z to try and get the patient to be, feel, as well as possible, and to still, be functional, but really finding out what the goals of the patient are, the goals of the family, and then as a health care team, how can we help them accomplish that? And then, what the alternatives are, if there are any. But to really work hard at making sure we try and achieve those goals, especially if they do say no dialysis. How can we then help with that conservative management, sort of change the mindset? I think tomorrow, I will say, I'll use the terms conservative management now rather than no dialysis. And it's interesting, having gone through this personally, I'm not sure I was saying that. I was saying things like no dialysis. And for patients that we have in the hospital, I had a patient yesterday who, 90 years old, who said no dialysis. And I think I would reframe our conversation saying, so you've chosen conservative treatment. Okay, we'll help you with that. So I've learned a lot today to I think, sort of change the conversation a little bit. And I teach residents and students, so I'm looking forward to sharing that. And I have a whole team of people on both units that I think I can share this information with.
And I guess the last thing is, what drives you to sort of stay involved in your end of medicine, and at least to speak out about the kidney disease things that you see? Given my internal medicine and geriatrics, so these are my patients also. Not so much the younger ones, because in terms of geriatrics, we tend to take care of a population that's over the age of 65. So just by the nature of my specialties, these are the patients I would need to know about, whether I went through it personally with my dad or not. But having that perspective, I have to say, I think has sensitized me even more. And so sort of it is what it is. You sort of use what you can, and then you hopefully become a better person and a better healthcare provider at the same time, which is good. So I will continue to do that. I love what I do. I love the geriatric patient population, and so we have to just continue to do a better job, get their stories. I talked about it with one of the other speakers today, about getting the story of the patient and then finding out what's important to them. So not just finding out what their goals are from a kidney standpoint and from a treatment standpoint, but what are their goals for their functional status and what's important to them, and do they want to go on a trip, and do they want to see their grandchildren? So I think, to me, that we can do that no matter what our specialty is or whatever the conference is. I think if we sort of just work toward that as a team in a very, very busy world that we're in, I think we will have better partnerships with our families and our patients, and keep them at the forefront, but keep the things that are important to them really at top of the list. And so I'll continue to do that. I love what I do, so I'll continue to do that. And so, yeah. That was awesome. That was awesome.
I don't know.
Thank you.
You can tweak it as you want. You can do it. You cannot include me.
Tweak